Andreas, I might start with you. It was a fabulous talk because knee replacements, as good as they are, the patients are not always happy. Let's talk about manipulation first, if you don't mind. What does a manipulation achieve, and do the effects last?
Manipulation is not common. I would have a rough guess that perhaps 1 in 20 of the patients I treat needs a manipulation.
Sorry, Andreas, just speak up a little bit, please.
I'll try and swallow this microphone. I was just saying a manipulation probably happens in about 5%, 1 in 20 patients, when at somewhere around 6 to 8 weeks, together with physiotherapy and with a lot of efforts to increase the range of motion, they're stuck. Let's say it's 70 degrees. 70 degrees is not satisfactory because 70 degrees means you can't get your foot under the chair when you're trying to get up from the sitting position. There are lots of things which are difficult to do at 70 degrees. It's not satisfactory because ideally we aim for 110, 120 degrees of flexion. So that patient, having had some x-rays at that stage to make sure we're not dealing with any surgical errors, will get a manipulation under anesthesia. They are, of course, worried about it being painful. And yes, afterwards it is a bit painful, but not as painful as many patients fear. They have a general anesthetic, and the surgeon cautiously puts additional pressure on the knee, flexing. I usually press proximal tibia so that you don't have a long lever arm to cause injury. And then you can feel those little bits of scar tissue break. You can sometimes hear that. And I always take a picture for the patient afterwards, just holding the thigh, and you see the foot fall down, and that gives them a bit of visual feedback that at the time of the surgery, when they're asleep, when they don't have pain, they can achieve that. Does it last? In most patients, they only need one manipulation, and it's a very big step forwards. They gain 20, 30 degrees of flexion on the spot, and that helps you, the physiotherapist, then to achieve further flexion. Will they have a normal knee? Will they have full flexion later on? Probably not. They will always be on the stiff side, but very few people need a second manipulation.
Thanks, Andreas. Chris, Ivan, do you guys also go early at 6 to 8 weeks like Andreas does if you're going to do a manipulation? I must say I've generally waited around the 10 to 12 week mark.
Yeah, I generally about 3. Well, it depends. If they're progressing, if they're progressing albeit slowly, I'll probably wait to about the 3-month mark. I tend to combine it with an arthroscopic division of adhesions, because my tendency, particularly if you're doing a little bit later, my observation is they tend to stiffen up a bit. So if you get in there an arthroscope and divide the adhesions, particularly in the superior patellar pouch and both gutters, that stops that happening. I also keep the patient in the hospital overnight on a CPM under it with a spinal, and I fill the knee up with local anaesthetic, and I think that gives a predictable maintenance of the improvement in range. And like Andreas said, well, as a bare minimum, you need 95 degrees of flexion. That allows you to ride a bike and go up and down stairs comfortably, but ideally we want more than that. But I think it's a very useful procedure, and patients get over it a lot quicker than they think, and often a lot happier afterwards.
Chris, what about you?
Yeah, my preference is about 8 weeks, or when they've stagnated with physio for 2 weeks. So if they're still progressing, I'll let them go. If you're really worried, I'll get to it before 3 months. I agree with Ivan, so I fill their knee up with local anaesthetic. I put 100 mils of local anaesthetic in their knee, which I think acts kind of like a hydrodilatation for a shoulder. When you're doing it, gives them really good pain relief and helps break up some of those adhesions.
Chris, I'll start with you, keep going with you now. How do you know when a knee replacement patient has overdone their exercise? Like, how do you know when to push them, and how do you know when to actually back off in that patient?
So I tell all the patients there's a difference between discomfort and pain. If you're training for a marathon, you need to be uncomfortable or you're not going to get faster, same as lifting weights in the gym. knee replacements are painful, but if they're in agony and they're loading up on opiates and they can't get out of bed the next day, then it just means they're doing too much. Now, some patients do need a little bit of a push because they probably don't understand the difference and they perceive discomfort as severe pain. But I think the majority of the time, your goal should be to keep them going and progressing without putting them in so much discomfort they can't do it the next day or later that day. So, that's generally my thoughts is if they're overdoing it, they're in severe pain, they're requiring opiates, that means they've done too much. If they're trucking along in some discomfort, knowing that they will never be pain-free initially, then that's fine.
Andreas, any different thoughts on that?
I'll share a little anecdote. Many years ago, when I was a trainee, I went on a round with a surgeon who's no longer with us. He is a bit of a strong personality, and the patient said, "How often do I do those?" And he looked at the patient and said, "Just do them 1,000 times." And a few weeks later, the patient came back quite dismayed and said, "Look, as much as I tried, I only managed 700. And it's very rare that patients overdo it, but we do have patients who think that they can speed up healing by doing more, and they just simply can't. They'll just inflame it. Where that balance is very individual, and that's why I encourage everybody to look at these people, talk to them, find where they are, what their ambitions are, and a few need to be slowed down.
Thank you. Ivan, do you let your knee replacement patients run afterwards? And if you do, does big muscles help protect against polyethylene wear?
Well, I let them run to avoid getting run over in traffic. I tend to encourage them not to take up running as a recreational pastime, and play impact sports and that sort of thing. I mean, they can play tennis and they can go skiing and that sort of thing, but impact and it's impact with running is not great for even with the highly cross-linked polyethylene. It's going to lead to increased wear. And there's lots of other things you can do to give you the same amount of exercise. So, no, I don't encourage it. People do what they want to do, though. They're individuals.
Anybody in the audience read the last question for physiotherapists? No? Catherine did. Yeah, it was on return to sport after knee replacement. It was written by Sher. I don't know if he's here today, but anyway, if you are interested in a more detailed breakdown of that topic, go back to the website, go to the question for physiotherapists, and there's an exact breakdown there. The problem really with returning to sport is these patients don't have proprioceptive function. Even 2 years after having had a knee replacement, there is a definite, if they've got a native knee and a total knee, there's a big side-to-side difference in their proprioceptive function, and so they're much more likely to injure themselves if they go to any form of sidestepping or long-distance running type sports. And having bigger muscles doesn't do anything to prevent the poly wear, unfortunately. So it's not something that I would recommend for patients, but we can't control them. Some people do it. All right. Chris, you see a young child walking either with pigeon toe, walking with pigeon toe gait. What do you do at that point? Is observation enough? Is there an age bracket that you do this in? And what should we do?
So it's in-toeing, out-toeing is a variation of normal. The main thing is to work out why they're doing it. Now, kids that are in-toeing, what they're doing is with their femurs, they're moving their trochanters forward, so they're internally rotating their hips. Internally rotating their hips to move their trochanter position forward, to stretch their glutes, to provide a stronger lever arm when they're walking. And this is very common in young children as they start to run. So initially children walk like drunken sailors. They walk with their legs out because their cerebellar function is poor. And then as they start running at about the age of 18 months or 2, they start in-toeing because they're trying to generate force. Now, if they're severely in-toed, we want to make sure that it's not a hip problem is the main thing. So increased femoral neck anteversion or antetorsion is associated with hip dysplasia. So if anyone's got very severe in-toeing, I'll get a pelvis x-ray for them, but that's very uncommon. Most of the time it's examining their hips, make sure they move freely, work out where the torsional malalignment is coming from by doing a prone rotational profile exam. So you lie them on their stomach, you check their hip internal external rotation in full extension, check their their tibial, their intermalleolar axis and their foot thigh angle, and if everything's within the bounds of normal, just leave it and watch and reassure the parents that most of them will get better.
Thank you. Andreas, what's your trigger to operate again on a stiff knee replacement, and what do you typically do? I haven't mentioned an arthroscopic release, but some people do full open releases at some stage as well. Would you just share your thoughts on those questions?
Well, you've already heard from our answers earlier that we differ slightly. I do a manipulation earlier than Ivan does, and I do very rarely an arthroscopy afterwards. I have reoperated occasionally on knees, but they have to be actually very stiff, and I've done so for a patient who had probably a condition like arthrogryposis or something like that in an adult, because everything else went stiff, and one has to be very careful because the results of reoperation on the whole is disappointing. Now, if we can identify preoperatively that there was overstuffing of the femur, then one can change that. Sometimes we can reduce the poly in the tibia to get a bit more range of motion. I'm very reluctant to operate on the whole, and I can say happily that my experience is very few because I haven't had to do it very often.
Fantastic. Do you think patients with inflammatory diseases are more likely to be unhappy after their operation? Pain, swelling, stiffness? Or is there... Yeah.
My observation with patients with inflammatory conditions, especially rheumatoid arthritis, is just the opposite. I feel that patients with rheumatoid arthritis seem to have an unbelievable tolerance for discomfort, for pain. They're already used to so many other problems. They are actually the least likely to complain in my view.
Thank you. I'm just going to take a couple of questions on the diet stuff that also come in from the webinar about protein shakes, protein supplements, and things like that. So the reality is the best thing for the person to eat is a natural product which doesn't have sugars and sweeteners and a whole lot of other associated materials in it. So if they can eat the meat, the chicken, the fish, that's their best option. Now, if they're having trouble getting that down, then yes, you can use a protein supplement, you can use a protein shake, but just understand that you're getting a whole lot of other stuff with that, which you probably don't want to have in the person's system as well. But is it better than not having the protein? Yes, it's better than not having the protein. What do we do about vegans? Well, it's a problem, all right? Now, being vegan or meat eating, it's a personal ethical choice, and I don't mind one way or the other. But if you're vegan or vegetarian, you're going to have a much, much, much harder time to achieve the same outcome. You're going to have to spend a lot more time calculating exactly what you're eating down to the last sort of amino acid almost, because if you eat using things like pea proteins, you're going to have nearly 5 times as much of the protein to get the same outcome as eating an animal protein. Now, I understand that's an ethical issue that some people don't want to go down. It's okay, but just understand that it's much harder work to do it that way. Chris, what's the oldest age you can brace a child with DDH?
Preferably pre-walking. I've put 16, 18-month-olds in braces, but they tend to be very unhappy with it. Essentially, once the child can undo the brace themselves, you're probably stuffed. You know, they're all held on by Velcro straps, and 18-month-olds, they're pretty sneaky. So Post-surgery, they'll tolerate it. So if I've done an open reduction, I put them in a brace afterwards, they'll tolerate that for a couple of months. But the ideal time to brace a child, if their hip is dislocated, is within 3 days. If their hip is reduced but dysplastic, we want to put them in a brace somewhere between 6 and 12 weeks of age, or the first time you see them.
Okay, thank you. Andreas, a patient comes to see you for a second opinion. It's 2 years since their knee replacement. Is there any point trying a manipulation in that patient?
No.
Excellent. Now,
However,
that same
we probably spend a lot of time, a patient like that, to, especially with a second opinion, to go through the details of the surgery, look at the x-rays, sometimes get a CT scan and the like. And some of these people need actually counseling, because if they lasted for 2 years, they maybe need to put up with that knee, because the chance of making that better, if I may say, there's an old saying that if something's buggered, you can't unbugger it by rebuggering it.
So Andreas, you said that psychology can improve the physical function of a knee replacement. What do you mean by that?
I appeal especially to the experienced and senior audience, and I want to ask actually how many agree with me that psychology is a very important part of looking after patients of all sorts. And I see lots of hands going up here. And that's something which in my orthopedic training was entirely lacking. We got a little bit of that from talking to senior colleagues, but there was no formal training in the psychology of patients. Now, those of you who have been unfortunate enough to be patients yourself will know that even more, that it's a most uncomfortable time when you're a little bit in no man's land. And that's where psychology, reassurance, asking patients about their perception of their progress, their illness, I think it's a most important part to improve physical function, because we need motivation to get people going, and we need to reassure that what they're doing is the right thing and not harmful for their long-term outcome.
Yeah, it's extremely important. About 30 to 40% of any treatment effect is placebo, which is enormous. So as treating physicians and physiotherapists, we can take advantage of that. It puts us ahead of the game to begin with. Conversely, the nocebo effect has an equivalent effect. So if a patient thinks they're going to go badly and they've convinced themselves they're going poorly and having a negative outcome, they will have a negative outcome. So it's really important to take a lot of time coaching the patients, and it's actually really important to get the patients, see where they are personality-wise, because you can have a profound effect on that patient's outcome with psychological intervention. You don't need to be a psychologist, you just need to know how to encourage them and change their mindset. So it's extremely important.
No, that's very true. There's a few questions also on ERAS protocols and carb loading before surgery. Now, the current New South Wales ERAS protocols do not recommend carb loading, because all the studies that have been done on it show that it made basically no difference. There was a slight difference in post-operative nausea and vomiting, but now most hospitals are starting what's called a sip to send program. They'll stop solids 2 hours before surgery and then let the patient continue to sip on water basically until they get sent for in the hospital. It's taking a while for this to disseminate throughout all of the hospitals, but there are some of the public hospitals leading the way with this, and that definitely reduces post-operative nausea and vomiting, and also is very helpful to reduce insulin resistance. A couple of the studies on carb loading showed increased insulin resistance and actually a detrimental effect of carb loading. So the best thing to do is, the weeks before the operation, leading up, really bump up your protein. In the lead up to the actual operation, keep sipping on water so you don't get dehydrated. And basically, as soon as you can eat afterwards, start bumping up your protein as well. A few questions on amino acid supplementation. Again, none of this is as useful as simply eating real food. You can do all of these other things, but the message should be to our patients, let's eat real food to actually help ourselves get better. Andreas, if you think a patient's depressed, or if the physio thinks that the patient's depressed, do you think they're better off calling the surgeon or the GP?
Well, it's actually important that you talk to one of us and pass the message on. If you think there's a problem, then we need to share that. And it depends whether you as a physio have more contact with the surgeon or the GP, but contact one of us. We have these days a lot of help with, I believe, quite good drugs to help people with depression. But apart from that, it's actually a question of addressing the problem. It doesn't mean necessarily drugs or seeing a physiotherapist. Sometimes that patient who needs a bit of extra attention in our teamwork, it involves both the surgeon and the GP. The main thing is communicate and share your views with us. That's really the message I'd like to send to you.
Chris, for a skiffy hip, what are the correct X-ray views to order, please?
So for a skiffy, you just want a pelvis AP and frog leg lateral. That's all you need to do for them. That will give you all the information. If there's nothing on it, but you're still really concerned, get an MRI, because that will show you a pre-slip in someone who's about to go.
And what do you write on your ultrasound request form for the hips that you want ultrasounded?
So for the baby hips, you just write bilateral DDH ultrasound, and that's all you need to do, and they'll do the views that are needed on both of them at any of the imaging places. Okay,
fantastic. Andreas, what do you think? Sorry, Ivan, let's go to you. How common is patellofemoral instability after knee replacement?
Very uncommon in my practice. I very rarely see it, but it can happen. I mean, the issue with patellofemoral instability in knee replacement is often due to malrotation of the femoral component. If the femoral component is either too neutral or too internally rotated, the patella will tend to sublux laterally. Also, if the lateral retinaculum is too tight, and people haven't done a lateral release when it's required, it mightn't present as instability, but it can present as patellofemoral pain due to a tight lateral retinaculum. So it is very unusual, but see it occasionally. It can be quite difficult to treat and may require a revision of the femoral prosthesis. But often a lateral release would be enough.
Andreas, Chris, any different comments to that?
Not really. It's not common. We see it much more commonly in other people, in young women without knee replacement. But after knee replacement, it's not common. We do see some people who I think have, especially with the valgus knee, who have a little bit of drift on the skyline views, and it's not always certain that that's the cause of the pain. In fact, cause of pain is difficult to determine post-knee replacement, and none of our tests actually show pain, whether it's an MRI, a CT, or a bone scan. We have to infer pain from what we see in the physical examination, and asking patients their history will be more helpful than the investigations.
So a Nobel Prize winning test. If you can work out how to show pain on a test, there's a Nobel Prize for you. All right, so the last question I'm going to take is, does the timing of protein intake matter? So if you're on a relatively high protein diet for a period of time, the body will adapt, and so what will happen is that your high protein amino acid cycle will actually last probably 16 to 18 hours. So it's not so critical when you have your protein in relation to your exercise. If you're someone that's for the first time bumping up their protein, then ideally it should be within 2 hours of exercise. It doesn't really matter too much if it's before the exercise or after the exercise, but if it's within about 2 hours, you're going to get the best benefit of that protein load around the skeletal muscle loading. All right, thanks to this panel.